So we're going to talk about the lower GI tract. Colon cancer is one of the most common causes of cancer in the United States. It's the second leading cause of cancer death, and which is a sad case because it's something that's so preventable. You know, pancreas cancer, that's just like really bad luck, right? But this is something that we can prevent by removing polyps, which are the precursors to cancer. So it is defined as cancer located in the colon or the rectum. The rectum, this is abbreviated CRC, colorectal cancer. The rectum is part of the colon. It's a little bit of a special situation, surgically speaking, and so I think that's part of the reason why they separate these two out. The lifetime risk is about 5%, okay, compared to the lifetime risk of, say, pancreatic cancer, less than 1% for across the board. The natural history of this is such that a polyp takes about 10 years to go from polyp to cancer, 10 to 15 years. So we have a really long time in which to intervene and remove polyps, which is a lovely situation for people that we can really make a difference for them with polypectomy. In some conditions, genetically, it takes a shorter time, but in your average risk person, this goes through a long sequence of polypectomy, of polyp formation. At this stage of growth here, and even sometimes at this stage, people have no symptoms. And so, you know, sometimes when I'm talking to patients, like, you know, how about a colonoscopy? And they're like, I couldn't possibly have anything because I feel fine, you know, and you really won't feel a polyp until it becomes an invasive cancer here. And then you might start getting symptoms, bleeding, et cetera, but many times no symptoms at all. So again, mostly asymptomatic, okay? And sometimes people will come for a screening colonoscopy, you know, and they've got a cancer. Like, how could this be? I had nothing. But they can be asymptomatic. Suspicious signs and or symptoms, the lower cancers, especially those of the rectum or the lower, the left colon, often will have bleeding that you can see, okay? So they'll say, I've seen blood in the toilet when I have a bowel movement. Emergently, a fair number of people present with a bowel obstruction. They've sort of been a little iffy. Gosh, I'm a little more constipated lately. And then they come in with a big bloated belly and nothing's moving through because it's obstructed. The tumor finally got big enough and closed itself off enough that now they've got a bowel obstruction. So for screening, who gets screened? Anyone age 50 and older. If there's a family history of colon cancer, okay, say your mother had it at age 50, then we go earlier than that. We go 10 years prior to the person who had the cancer that was related to you. Some colon cancer syndromes predispose people to making a lot of polyps, okay? And the two main ones are something called familial adenomatous polyposis, FAP, and Lynch syndrome. And those people will make a lot of polyps at a young age, and those polyps grow faster into cancer, okay? And so that 10-year window, they don't have that, and so they have to get colonoscopy quite a bit more frequently once it's identified. The FAP patients, the risk is 100% that they'll get cancer, so they have to have their colon taken out, okay? So if they have that. Inflammatory bowel disease, Dr. Tierney is going to talk about, but people with long-standing inflammation of the colon, whether from ulcerative colitis or Crohn's disease, once it's been 10 years or so, their risk of getting cancer goes up just because of long-standing inflammation, even if they're young. There are a number of screening tests out there for colon cancer. And the reason these two are highlighted, and I'll talk just a bit about them, is that there's a multi-society task force that includes all three of the societies, the experts in the field, who wrote a document on this situation. Like, there are 9 different screening tests. Like, what a confusing thing for people. And we really think that colonoscopy should be offered first, and if refused, then the FIT test. The FIT test is the fecal immunochemical test, and that detects blood in the stool. But it's different than the old guaiac-based stool test because it detects intact blood, okay? The guaiac test really detected blood, so you could have brushed your teeth and had some bleeding gums and swallowed that, and your stool test would be positive, right? It was because you had bleeding in your upper GI tract somewhere. Whereas the FIT test is really colon specific, so it's quite a bit better for colon cancer screening. The thought is that some polyps, even at the polyp stage, will have a little bit of bleeding, and then it'll be picked up by the FIT test. And then that leads to a colonoscopy, okay? And so if your FIT test is negative, you get another one the next year and another one the next year. You go every year, and even though FIT isn't perfect, it's far from perfect for picking up big polyps, which is what we want because those are the ones that are going to become cancer. the thinking is that by doing it every year, you're going to pick up some of those. There are definitely some problems with FIT, but it's cheap. And so insurance companies, and it's also easy to do. You don't have to get prepped. You don't have to get sedated. You just do it at home, mail it in, and there you've got your colon cancer screening. So there are definitely some problems with it, but it's about $22 or something like that, and it can be done at home. And so that's a nice test. It can't detect everything, okay? And additionally, it can't remove polyps, right? And so that's why colonoscopy, we think, is a better test, and it doesn't have to be repeated for a long time, like 10 years, right, if you don't have anything. So you can see the other ones there. The stool DNA test is out there. You may see some ads on that. That's quite a bit more expensive. It's a little bit better than the FIT test at picking up polyps and cancer. Not a huge amount better, and it's about $500 for Medicare rates. Barium enema is putting barium up the rear end, turning the patient this way and that to get it to coat the colon or taking an x-ray. It's really no longer used. It's not good enough. It's no longer used for colon cancer screening. Flexible sigmoidoscopy means a short colonoscopy, just looking up the left side, okay? Most people don't, we don't prefer that because you're just looking at part of the colon, and we know many cancers rise from the right part of the colon. The CT colonography is the CAT scan of the colon, and that's been around for a long time. There was such initial interest in it, especially from patients, they don't have to do a colonoscopy. The problem with it is that it can't see smaller polyps. You still have to do a bowel prep. They put a tube in there and pump a bunch of air, and so it's quite, it's uncomfortable. And if there's something found, then you still have to get a colonoscopy. So it really hasn't taken on much interest in screening. Sometimes we'll use it for an incomplete colonoscopy. Just couldn't get to the end of the colon. It was, strictured or whatever, and so we'll use that. This is what colon cancer looks like. You've seen what a normal colon looks like. Here's a giant tumor here. This is the transverse colon. We know that because it's sort of triangular in shape, and this is a large cancer there. There's really nothing else that this is going to be. Okay, so we can usually tell people, I think you have a colon cancer, and their next question is, can it be removed? It can be removed, but the question is, has it spread? Okay, so after we see this, we biopsy it and we tell them, well, I'm not 100% sure until my biopsies come back showing this, but I'm pretty sure. And then we get a CAT scan, usually the chest and the belly, especially if it's in the rectum, because that can spread straight to the chest. Until we get that, then we don't know if it's really curable or not. Okay, these tumors like to spread to the liver, sometimes to the lungs, and so until we get that CAT scan, we just don't know. All right. So if it's localized, meaning it's just in the colon, we did a CAT scan, the tumor is just in the colon, there's nothing in the liver, nothing in the lungs, maybe there's a lymph node or two out there, that's okay, that can come out with the surgery. And if it's farther enough away from the rectum, away from the anus, they can take out that section of colon. How much colon they take out is a little bit dependent on the blood supply, okay? So they have to take out the whole section fed by that artery. You can't take out like part of it and take the artery with it, the rest of it will die. So you take out that one section with its artery, and then they usually just hook the two ends back together. Patients always worry about having to wear a bag, okay? Sometimes they do have to wear a bag for a little while if it was an emergency surgery, like it was obstructed and they had to go in emergently. But most of the time they can hook it back together. Now, if it's too close to the outside, right, if it's too close down to it's in the rectum and it's really low, the surgeons have to take the whole thing out, and sometimes they have a permanent ostomy because of that. That's called an APR, abdominal peritoneal resection. It's just they didn't have enough room to sew anything back together. So this is kind of a treatment phase. Palliative care means just making the person feel better, I guess, holding their hand. There are many other aspects to palliative care, pain control and that kind of thing. One interesting thing to point out here, this person getting chemo looks like she's about, 30, right? Colon cancer is increasing in young people, and it's not really known why, okay? So we'll see people in their 30s and 40s getting it. It's not known why. The screening recommendations are still the same to start at 50 for most people. That may change at some point, but right now it's still 50. But we do see young people. I've seen pregnant people with colon cancer. Like, it's insane. So that definitely happens. And okay, so moving on to lower GI bleeding. This means bleeding from the GI tract located after the ligament of Treitz, which is a ligament on the outside of the duodenum. It delineates the end of the duodenum, that first part of small intestine, from the jejunum. We can't see it through the scope. It's on the outside, but that's how we define lower GI tract bleeding. These percentages here mean that if you have somebody who you think is having a lower GI bleed because they've got blood coming out of their rear end, like red blood, about 10% of the time it's actually from the upper GI tract. If somebody's pooping out red blood and it's coming from the upper GI tract, that's a big bleed, a rapid bleed. And the reason is because as blood makes its way from the stomach through the GI tract, it gets digested and it turns black, and that's called melanina. And so that's how we usually get a clue. If somebody's having black stool, we think, well, it's probably coming from upper GI tract because it got digested. If they're having a red stool, which is called hematochezia, and that's on the next slide, we think it's probably coming from the lower GI tract. But if somebody comes in really unstable and they're pooping out red blood, there's a small chance it's coming from the upper GI tract. And then we have to decide we want to take a quick look up top before we proceed with a colonoscopy. The small intestine, that 20 feet of small bowel that does so much work for digesting and absorbing, really doesn't misbehave that much, which is so nice because it is super hard to get to. It's far away from the mouth, it's far away from the butt. And so it really doesn't misbehave that much. It doesn't make cancer that much. It doesn't bleed that much. When it does, it's a problem though, because it's so hard to get to. So most of the time it's not from the small bowel. So symptoms of a lower GI bleed: hematochezia means bright red blood coming out of the rectum, usually from the colon somewhere. Melena is black stool. It has a very particular smell, and once you smell it, you'll know what melena smells like. That's usually coming from the upper GI tract. A small percentage of the time, it can be coming from the right colon, the ascending colon, and it just got digested as it made through, usually not a very rapid bleed. Symptomatic anemia means somebody's been bleeding for so long that they've come in and they say, I can't walk to the bathroom anymore without getting short of breath. They have nothing in their tank. They'll come in with like half of the amount of blood that they should have. They've tolerated it because it's been a long time coming, right? It's not an acute bleed. It's been a long time coming, and their blood is just more watery, right? They don't have as many red blood cells. They're out of iron, but blood's just more watery. They come in kind of symptomatic. They can also, if they have enough of a rapid bleed, they can pass out, right? Okay, and so you can get syncope. That's what that word is. Syncope means passing out, loss of consciousness. So here are the usual causes of lower GI bleeding. We'll go through diverticulosis. That's that one up on the left side, looks like kind of like Swiss cheese. A very common cause of lower GI bleeding. Angiodysplasia looks like little spider blood vessels in the colon. That's a less common cause, especially for a big bleed. Ischemic colitis, the third one there, is a temporary shutoff of blood supply to part of the colon. And the reason that happens, there are a couple of areas in the colon that have marginal blood supply anyway, both on the left side. And so the tiny little branches of one artery are giving out and tiny little branches of another artery are taking over. And so those areas don't have great blood supply anyway. They're fed by small vessels. And so they're called the watershed areas of the colon. And so usually it's an old person who got dehydrated or maybe got their blood pressure lowered, and that area of the colon doesn't get enough blood supply, and it causes the lining to die. And so what they get is pain and then a bloody stool. It's always the same thing. It hurt, and then I started having blood in the stool, and that's ischemic colitis. That's that purpley picture there. That's a self-limited thing. It usually stops on its own and gets better without any sequelae. Hemorrhoids, we'll talk about a little bit later. Colon cancer, we already talked about. These rarely come in with acute bleed. I think I have seen maybe one person, was playing golf and started having blood in his stool, and it was a colon cancer. But usually that's more of a chronic, like, I've been seeing blood in the stool for 6 months, or they're iron deficient. Inflammatory bowel disease, definitely a common cause of bleeding in the young. Usually not a big bleed getting admitted, but a chronic thing. Infectious colitis, that picture there is a picture of what's called C. diff or Clostridium difficile. It is an infection of the colon with a bad bacteria called C. diff, and usually associated with having had antibiotics. And so the thinking is that the antibiotics kill off the good bacteria and this bad one takes over. It's a big problem in hospitals, like infection control is a big problem. They can be very sick. Bleeding isn't a huge symptom of it. Rarely they'll have bleeding with it, but it's usually bad diarrhea, and they can be super sick from it. Post-polypectomy is the one that we care about, obviously big time as gastroenterologists. You can see here the cautery mark, from a colon polyp, and as I mentioned earlier, that will ulcerate, and if it erodes into a vessel, then you have a post-polypectomy bleed. So the first thing that people get when they come in with any GI bleeding is to make sure you have adequate IV access, because you have to give them volume. They may not even need red blood cells, but what they need is volume. Their heart has to have something to pump, and so you have to give them immediately volume. Sometimes in old people, you have to be a little bit restrained with it because they can sometimes have heart failure too, and you give them a bunch of fluids and they'll, just drown basically. But you want to give them volume right up front. Have to have something to pump. Some of them will get blood. As I mentioned, the criteria for transfusion have gotten quite a bit more strict, in the last 10 years or so. We really try not to transfuse people unless they're really actively bleeding or it's down below a certain level. As I mentioned, for somebody who's having a rapid bleed, they're pooping out blood and they're unstable, we'll often, even though we think, gosh, that's fresh blood, it's probably coming from the colon, we'll often go in and do an upper endoscopy first. You can also try and exclude an upper GI tract source by putting an NG tube in. That's a fairly big tube that goes down the nose into the stomach. This is done in an awake patient. You might imagine they hate it. The problem with the NG tube is if the bleeding's coming from the duodenum, okay, it might not be refluxing up enough into the stomach for you to pick it up on your NG tube. You just suck out what's coming out. You attach that to suction. Is there blood in the stomach or not? And you think, oh, okay, it's upper. It's not colon. It's upper. I've got blood coming out. But again, if it's coming from below the stomach and the blood didn't reflux into the stomach, you're going to have a negative one and be falsely reassured that it's not an upper GI tract. Again, you can do a quick upper endoscopy. It's so easy. It takes 10 minutes, and you can exclude an upper GI tract source. Not so with colonoscopy, right? That takes a bowel prep. It's going to be a few hours before you can do a colonoscopy for a lower GI bleed, and so an upper is sometimes done. Now, if it's not a big bleed, it's clearly lower. Not everybody does an upper endoscopy for bright red blood coming out of the bottom. So what do we do? Except in the setting of post-polypectomy bleed, colonoscopy is not as valuable as one would hope, okay? It's just not as valuable as you would hope because most of the time it's diverticular bleeding, and to find the one diverticulum, outside of a few investigators who swear you can find it every time, is hard. I mean, it's hard to find it. Like, all you see when you go in there is a sea of red and a sea of pockets of diverticuli, and I'll show you what those look like. But to find the one, and they all have blood in them because they're all pouches, and whatever bled, it just collects everywhere. So it's hard to find the one, and many times it just stops by the time you get in there. But for post-polypectomy bleeding, it's easy usually because you have the report where the polyp was that was taken with cautery. You drive to that. There's always some bleeding vessel that looks like this thing on the top, and you put a nice clip on it and you're done. You can do thermal therapy too. I don't love doing thermal therapy in the colon because it's already thin there because you lopped off a polyp and made a little ulcer, and you got a better chance of perforating. I love clips for this. I think most of us would agree with that. If you find the diverticulum that's bleeding, you can put a clip on that. And I used to worry a little bit about clipping it shut. It doesn't seem to be a problem. And I'll show you the pathophysiology of that in a minute. You can inject epinephrine through your little needle, okay? And that, again, shrinks the blood vessels in the area so that they don't bleed as much. And that epinephrine alone will usually sometimes get control of it or slow it down so you can see very well, but alone it's not enough. You have to do some kind of mechanical therapy, whether it's cautery or banding or clipping to be definitive. Epi alone doesn't buy you. It buys you a little time. Okay, APC can be done for these superficial bleeding lesions like this angiodysplasia. You can see a little lightning thing there, which is very cool. Radiation proctitis is always limited to the rectum, and it is usually in men who have had radiation for prostate cancer. The prostate's just on the other side of the rectum, and when they have radiation, it can sometimes affect the colon and make a bunch of these little angiodysplasia type lesions that can bleed chronically, and you can treat it very effectively with APC. So what is diverticulosis? These are just outpouchings of the colon mucosa. That the mucosa means the inner lining of the colon, and it just the colon just makes a pouch at a weak point in the wall. And so what you see are these little pouches. Patients always ask, why do I get these? There's probably some genetic component. About half of people over 50 have them. So I have this conversation like every day. It's not anything you did, although it is becoming more and more common. So there's thought to be maybe some dietary issues, red meat, et cetera, which is just bad for everybody, but so delicious, obviously. And so we really see this genetically probably and with age. Most people don't have any symptoms, and most of the time they're on the left side, sort of over in the sigmoid colon area. Usually we just find these incidentally, although sometimes we find them when somebody has symptoms and we're looking for them. This is the barium enema that we don't use for colon cancer screening anymore. We sometimes use it for other things, but you can see that barium has gone in through the patient's rear end. They also put air in there as well to get a nice outline, and you can see the dye in these little pouches here really nicely. They show up really nicely on barium enema. On colonoscopy, what we see are just these pouches here. There can sometimes be so many that it can be hard to figure out where the actual lumen is. Like, where do you need to go? And you're like in the middle of a tick before you think, oh, I don't need to go in there. And you got to redirect yourself because you definitely don't want to drive through one of these. You'll have a perforation. So the complications of diverticulitis, diverticular disease are diverticulitis or diverticular bleeding. Diverticulosis just means you have them. Itis means they're infected, and then you can have bleeding. So diverticulitis is inflammation of a diverticulum. It's sort of like having appendicitis on a small scale, although it can be very severe. This is similar to appendicitis, usually on the other side, though. They just get sometimes something gets stuck in there, usually a little stool ball, but it causes it to become swollen and obstructed, and then sometimes they'll have a tiny little perforation of the wall here, microperforation, and they get bacteria out there, and it irritates the abdominal lining, okay? And so they get a lot of pain. They'll have pain, fever, high white count, and so it's sort of like a tiny little appendix on the other side. Usually easy to diagnose with a CAT scan. With a CAT scan, in case you're not oriented, the person is laying on their back with their feet coming towards you. Okay, so this is the right side, this is the left side, and you're scanning, you're taking slices of somebody this way. Okay, so their feet are coming out at you. That's how you know it's right side over here and left side. This is their backbone, pelvic bones, and intra-abdominal organs. It's hard to tell, just like with endoscopic ultrasound, but this is an area of inflammation. Okay, the rest of these, this is contrast that the patient drank inside the GI tract loops. We're low down enough that there's not really anything else of interest on here. These are just paraspinous muscles. This dark stuff is just fat. So the person's healthy. They're healthy, as we say. Okay, so the treatment for uncomplicated diverticulitis, they just have pain. They don't have a big abscess. They're not in the ICU, or just antibiotics, okay? 10 to 14 days of antibiotics. It usually takes a while for them to start getting better. I mean, they'll still feel it in there for a few days. If it's complicated, like a severe bout of it, they've got an abscess, they've got something that needs to be drained, sometimes they need to have surgery. IR stands for interventional radiology. Those are the radiologists that drain things. They can put a tube in and drain it under CAT scan guidance, okay, to get the pus out. Antibiotics cannot reach pus. If it's a pocket of pus, it has to be drained. Sometimes they have to be operated on. It's a hairy operation to go in for an acute diverticulitis because everything's inflamed and matted together, and so usually the surgeons like to let it cool off before they go in. Diverticular bleeding is when, this is a cross-section of the colon, when an artery erodes into the base of a diverticulum. I don't know that I agree with this statement here. Bleeding is usually mild and self-limited. I mean, they can come in with a big bleed, but it does usually stop, and it usually stops after they've drank their bowel prep, and they're like, well, do I really need to go in and do it? You know, that we know they have diverticuli. But they basically come in with large volume hematochezia, red blood out the rear end. It's usually an older person. They're like, I had a bowel movement this morning, and then I went back, and it was all blood, and then I did it again, it was all blood, and then I passed out and whacked my head, okay? So that's the usual bout of a diverticular bleeding, and then they come in, and you make them drink their gallon and go lightly, and then it stops, and you're like, ah. But still, we go in and look. I know it's very unsatisfying. I don't love the diverticular bleeding. Treatment, again, here is colonoscopy, and you can identify the tick that's bleeding, good. Angiography, if they're bleeding so rapidly that you can't prep them, they can't have anesthesia, they are too unstable. The radiologist can go in usually through either through an arm vessel or a groin vessel. They shoot what's called a mesenteric angiogram. They shoot dye usually into the inferior mesenteric artery that feeds the lower colon. They can see the area that is, so this is dye in the blood vessel. They can see if there's an area of extravasation. That means dye coming out where it shouldn't be, and they send a little coil or plug and plug that vessel up. Very nifty. Most of the time they get in there and it stopped too, and then they're just up all night. Hemorrhoids, final slide. These are swollen veins in the anal canal. You can have internal ones that are above what we call the dentate line, meaning the junction between rectum and anus and outside, or ones that are on the outside. That's the external ones. Pretty much everybody has these, okay, but they can get really big. The older you are, just because of living on the earth with gravity, is making them big. And then some other things that will cause them to be bigger. Pregnancy, because of the weight of the baby sitting in the pelvis all that time, everything gets congested. These veins don't have valves. Once they get big, they don't shrink back down, okay, but they can definitely get worse with some different conditions. Sitting and straining, sitting on the toilet all the time and straining a lot can definitely cause the pressure in them to increase. They can get very big and bulge out. Chronic constipation is a big cause. So people are straining and pushing all the time, and they can just make their hemorrhoids worse. The treatment, most of these can be handled conservatively, meaning we give people fiber to start with. You can put some topical creams on them. A sitz bath is just basically soaking in a bathtub for 15 minutes twice a day. That's more for the external ones that have gotten inflamed and painful, and you just soak for a while, and that can sometimes help. There are a few procedures that some, not all GI doctors and many all colorectal surgeons will do, called a rubber band ligation, which is similar to banding varices in the esophagus, except it's in the rear end. This is somebody doing one, and it looks horrible, right? You're like, OMG, like, please tell me that person's under general anesthesia. They are not. This is an office-based procedure. Recall that I told you that taking a biopsy or doing something like that in the GI tract, you can't feel it, okay? It's the same for the rectum. As long as you stay above that dentate line where there's really no sensation. If you accidentally band something down here, they will feel it and be very unhappy. But up here, you really can't feel it. You really can't feel it. And again, once that band falls off, there's a scar there and the vessel is gone, okay? You can also do surgery for these and some other types of treatment. I think that's it. Thank you for your attention.